All right. So it is 12 o'clock, so we are going to get started. Welcome everyone to Psychology Grand Rounds today. Excuse me. Just a couple of quick housekeeping things. As always, midway through the talk, we're going to post the Psychology CE attestation link into the chat. So just look out for that, to click on the link, follow it to get your CE credits. If you have any questions and answers, please post any questions, please post those in the Q&A, and we will review all of those at the end of the lecture. And right now, it's my pleasure actually to introduce our speaker, Dr. Lauren Lipner. For those of you who aren't familiar with Dr. Lipner, she earned her PhD in clinical psychology from Adelphi University in 2020, following the successful completion of her clinical internship at the Perelman School of Medicine at the University of Pennsylvania. Excuse me. She completed her postdoctoral fellowships at Adelphi University and Mount Sinai Beth Israel before obtaining a full-time faculty position in the clinical psychology PsyD program at LIU, the CW Post campus. Dr. Lipner provides clinical supervision to psychiatry residents as well as psychology externs and interns at Mount Sinai Beth Israel, while also serving as a co-investigator in the brief psychotherapy research program. Her research is focused on identifying and measuring the occurrence of ruptures in the therapeutic alliance, and she has recently received grant funding from the Society for Psychotherapy Research to study psychotherapy process factors that may predict premature termination or psychotherapy dropout. Her talk today, it's entitled Getting Back on Track, a method to assess therapeutic alliance ruptures for timely intervention. It's with pleasure now that I introduce Dr. Lipner.
Okay, thank you so much for having me, and thank you to the organizers, Maria Edmond, Christina Palmisi, and David Dorfman for having me today. And I want to say first, this is such a nice full circle moment for me because Mount Sinai is really where I cut my teeth in getting my training, and it just feels like such an honor to be here presenting Grand Rounds. So with that being said, I will share my screen. Hopefully that goes smoothly. All right. So I'd like to get started. As Dr. Palmisi mentioned, my talk is titled Getting Back on Track. And what I'll be talking about today is a method for us as clinicians to use that will help us assess the therapeutic alliance and identify ruptures reliably, which will allow us to intervene as needed. So hopefully you'll find this all useful, and I'm happy to answer questions at the end. So I always like to start with this idea of why are we talking about this? Why do we need to focus on the therapeutic alliance? It's one of those things everyone mentions, but we don't really get into the weeds about. So I always start with this idea that therapy works, but not always, right? So the data suggests that patients might be non-responders as high as 30 to 40% of the time, or actually deteriorate or even get worse over the course of treatment, 5 to as much as 20% of the time. Then the other thing I always say is that therapy works, but only for the people that stay in therapy. And we have data to suggest, and perhaps even our own personal experiences can speak to this, that actually premature termination or dropout happens quite often. In fact, as much as 20 to 47% of patients will drop out of therapy. And the most common time for patients to drop out is actually right after session 1. So this is the bad news. The good news is that we know from the data as well that improving the alliance may also help us to improve those therapy outcomes that I've mentioned. In the same way that poor alliance might predict treatment failure, we also know that alliance ruptures can be quite prevalent, as much as in 20 to 50% of sessions, and can be predictive of psychotherapy outcome. And we also know, on the other hand, that rupture repair, or working with those ruptures, acknowledging them and ameliorating them, may also help us to improve those outcomes. So with that being said, maybe it's a good idea to start by defining the alliance. What are we talking about when we say this? Well, I'm basing my understanding of the alliance from Borden's original definition, back in 1979 as a tripartite model. Now, this was based on originally analytic or psychoanalytic constructs, now really thought of as quite a common factor or integrative variable. But we're thinking about three main components when we talk about the alliance, and that's our agreement on the goals of therapy. What are we working towards? Agreement on the tasks of therapy. How are we going to get there? What do we do in each session to work towards those goals? And also the affective bond. And when I describe this, I find the easiest way to translate that is to talk about what are the vibes in the room. And I'm sure when I say that, patients will come to mind right away of when we have good vibes and when we might have difficult vibes. That's what affective bond might be getting at. Now, more recently, we've started adding a bit of a twist on this language of talking about a purposeful collaboration, that it's not just agreement on the tasks of goals, but this is something that patient and provider are collaborating on to establish in a agreed upon way, and also the emotional bond being one that's characterized by trust and respect. So that's just a little more of a layered definition there. So as we've mentioned before, the therapeutic alliance has multiple times been shown to be an extremely robust predictor of therapeutic outcome, highly considered today as a trans-theoretical or integrative variable, meaning whether you are conducting a DBT session, a psychoanalysis session, or a CBT session, that this is relevant and useful and helpful. It's also been recently conceptualized as a change mechanism in and of itself, that in addition to some of the specific ingredients of psychotherapy that we might think of when we are wondering what works about therapy, that actually the therapeutic alliance can be one of those factors as well. And as we've also mentioned, poor alliances or weakened alliances are highly correlated with premature termination and treatment failure. So that's why we're here. So I've mentioned ruptures. Let's provide a definition for that as well. When I'm talking about ruptures, one way to think about it would be a deterioration in the alliance, which could be manifested by a lack of collaboration or agreement on the goals or tasks of therapy, and or a deterioration in that emotional bond or the vibes in the room. And generally speaking, we have divided ruptures into two different types. The first I'll refer to as withdrawal, which is really a movement away from the other, versus confrontation we'll think of as a movement against the other. And I'll follow up on this with some examples of what this might look like. But one thing I want to point out right off the bat is we are not saying this is something that's patient-driven nor therapist-driven, meaning we're not saying it's the patient moving away from the therapist or the therapist moving away from the patient. And that's on purpose because we believe that this is a truly dyadic process, meaning it could be both. And again, we are so interested in this concept of ruptures really because the data suggests that when we can identify these ruptures and intervene or work with them to improve them, we have real opportunities for change and certainly an opportunity to get this therapy back on track, hopefully preventing poor outcomes and dropout. So I really love these illustrations of the different types of ruptures that I talked about. We first have our withdrawal rupture. Again, that's movements away. And we see here the turtle retreating into the shell and hiding from the provider in this case. And that's contrasted to the confrontation rupture example, where the turtle, in fact, takes his shell off his back and is threatening to throw the shell at the provider. So you see, these are very different feels. And the one hand, we're looking for the therapist, for the patient, perhaps unable to reach them or understand what they're feeling because they feel distant. On the other, we feel perhaps under pressure or under siege, maybe not sure what to do next. So we can characterize this even further. When we talk about confrontation, we're really thinking about three general categories, and this is really based on the brand new version of the rupture resolution rating scale, which I'll talk a little bit more about, currently under development by Dr. Catherine Eubanks and Dr. Chris Moran. So three main categories here. First, we have complaining about or criticizing the other. What might this look like? This might mean complaining about the activities or the interventions being done in a particular session, complaining about the parameters of therapy, or progress or lack thereof in therapy so far. Next, we have pushing back against the other. This might look like rejecting the other person's suggestions or ideas, becoming defensive or defending oneself against some kind of perceived criticism that's coming across, and also denial or hostile denial would fall under this category as well. And finally, the last category here, we have controlling or pressuring. And I feel like this example is this is best illustrated with an example where we could imagine a patient, or perhaps we've had this happen, a patient coming in and saying, just tell me what my problem is and how to fix it. Just give me the answer, would fall under this category. Okay. Now, by contrast, I'll go over some illustrations for withdrawal. Once again, that's the movements away from the other or the work of therapy. And once again, I have three main categories to go over. The first is shutting down. This is where, again, either patient or therapist might have some minimal responses. Silence may be categorized here, or this feeling of giving up on the treatment. Avoiding may look like shifting the topic, avoidant storytelling, or talking a lot about things that just don't seem particularly relevant to what's going on or what's happening in therapy at the moment. And finally, masking, which we think of as including behaviors like content affect split. The best way to translate that would be a patient coming in and telling us a very intense or sad or scary trauma, but doing so with a smile on their face, which can often be a little off-putting or even confusing for us as providers. Another example of this might be deferential behavior. I've heard this called being yesed to death, or agreeing to things, but we might have some sense that maybe they don't actually agree with what they're saying they agree with. So that's just some examples of what these might look like. And it sounds great. It sounds like we would love to address ruptures as they emerge. That would be ideal. And at the same time, what we acknowledge and what my program of research was really inspired by is this idea that in order for us to work with and address ruptures, whether it's from a research perspective or a clinical perspective, we first have to be able to identify them. We first have to know that they're happening. This is the first step in allowing us to intervene. And unfortunately, data suggests that we can sometimes really struggle with this, that we are not always aware as providers when patients might not be feeling satisfied with treatment, and that this is something we could use a little help with. And this is really the main focus of my talk today, is providing a tool for us as clinicians to help us in tracking this alliance and making sure that we are not missing any ruptures that we should be addressing in therapy. And I hope you'll all find this helpful. So we had to start somewhere, and we started with this idea of thinking about a rupture as a V episode. So this is something we think of as happening over time. Now, we can imagine that alliance could be chugging along. If we were to take scores of the alliance, it would be pretty average. And if a rupture was to happen in a particular session, we might imagine that that score would drop suddenly. And hopefully, if we're able to repair that rupture, that in subsequent sessions, if we were to score the alliance again, it would raise up once again. So this is where we get this V episode idea from average alliance, sudden rupture, and therefore sudden drop. And then hopefully with a repair, we see that alliance score go back up to average once again. So we really think about this as a break in the average alliance development over time. So we were thinking basically, what are some tools that can help us to track this, given that we know we might have a hard time? So Dr. Eubanks back in 2012 published a paper that had some great suggestions for this. And one of them was this thing called control charts. So I'll explain to you a little bit about what those are. These are charts that are generated in statistical software that are used to track change in time series data. Quite a creative adaptation, because these charts were originally developed for use in manufacturing and actually to help us to detect any unpredictable variation requiring intervention at the manufacturing level. So we really borrowed this from other industries to see if it would be helpful for us in tracking the alliance. And again, this is widely used at Motorola and even GE. And in particular, we've focused on the Shewhart chart, as this is recommended for use in clinical settings. And you might be thinking, well, that sounds great. What does it look like? Well, here's an example. So this is one patient over the course of, it looks like 29 sessions, where we have a time series line graph, and each of these scores is an alliance score for each particular session. And this is from the perspective of our patient. So down at the bottom, we have session number. And on the left-hand side, we have alliance score. So in this case, the alliance measure ranged from 1 being terrible to 7 being perfect. And on average, this patient rated the alliance as being 5.7. Now, what I want to point out is that just graphing our alliance scores can really show us that this fluctuates over time and over the course of the treatment. So you're also seeing a couple other lines here. This solid line going across the chart represents the average alliance score for the overall treatment. Now, we also have these two dotted lines. These are referred to as control limits. We have an upper control limit and a lower control limit. And I'm particularly interested in that lower control limit, because what I have some sense of is that when we cross that lower control limit, meaning alliance scores have dropped, there might be a relevant change in alliance score that we might be interested in as providers. So in this particular case, I see that session 22 really seems like something must have happened here that I'd be curious to know what happened and learn more about. But also it looks like by session 23, things started improving. And by session 24, we actually crossed back over that average line, meaning things were back to status quo. So what I love about this tool is how idiographic it is. Every control chart is constructed for each patient, their reporting style, their scores, such that the control limits are set at a different number for each patient. These lines will be personalized to each particular person. And finally, I think this is just visually meaningful. Just taking a step back, it is very clear to me, even if we were to take these dotted lines away, that session 22, something quite meaningful happened that might merit further attention. So my study first started, or my research first started looking at, well, how do we set these charts up to help us to best identify sessions that we might want to take a closer look at or perhaps come back to in the following session. So one of the first things I looked at is, where do we put these dotted lines? This is the same patient. We see that if we set the dotted lines at sigma level 2, which really translates to like a standard deviation, meaning 2 standard deviations below average. We're looking at perhaps session 3 might be interesting, and session 22 for sure. If we change that to sigma level 1, or 1 standard deviation below average, actually now session 9 looks quite interesting as well. So my first question is, how do we construct these things? And my second question is, how do we know, or how can we say that this rupture has been resolved? Is it once a score has crossed the dotted line once again, as in session 23? Or is it once the score has crossed the average line once again, session 24? So I first started with, how do we construct these things? And how do we read them to know that we are determining or identifying rupture and repair episodes that are predictive of psychotherapy outcome using these control chart methods? So I won't bore you with the statistics and the results, but what we learned from that study was that when a rupture crosses the lower control limit set to sigma level 2, meaning that standard deviation of at least 2 standard deviations below average, that we are identifying a clinically significant or at least predictive rupture event that is related to ultimate psychotherapy outcome. And what I take that to mean clinically is that week to week, our alliance scores might change slightly, a couple points here, a couple points there. And that might not be something we need to be worried about. It is when we have these severe and significant drops following somewhat average development that we really want to be paying attention to and making sure that we are addressing in the following session. In terms of repair, what we saw is that we actually don't have to go all the way back up to average. In other words, we only had to cross back over that bottom dotted line for us to find rupture repair events that were predictive of psychotherapy outcome. So, in other words, what I take that to mean is that for rupture repair episodes to be predictive of outcome using these charts, we need to be more conservative with coding ruptures, meaning we really only care, or at least we only get worried when we have these significant drops of at least 2 standard deviations, not so much those minor fluctuations. But when we're coding or thinking about repairs, that it doesn't have to be perfect, meaning in the next session, we're not thinking we need to fix it all or go back to what was average or what happened before the rupture. But we do need to at least aim for some improvement so that hopefully the way I think about it is our patient is continuing to engage with us, meaning they feel that we are understanding them, we are able to address things when it got off track, and that we can move forward, even though we've had this misunderstanding with each other. So when I've presented this data before, I always thought it sounded great, but a question I always got, no matter what, was how do we know we're capturing something meaningful or clinically meaningful using these charts, right? These charts look very nice and they look very convincing. But did you actually watch the session to see if anything interesting was actually going on? And I thought, well, that's a great question. And we have a tool for that. We have, which I mentioned earlier, the rupture resolution rating scale. And this is, again, developed really out of some efforts at Mount Sinai Beth Israel and our research team in the brief psychotherapy research program there, which is an observer-based measure to assess for rupture process, both in terms of frequency and impact in 5-minute segments. So this is really a scheme where we can take a session that might look interesting to us and actually watch the tape and then code to see if we actually saw any rupture process going on. So a little bit more about that. This measure is equipped to tell us both about those withdrawal rupture markers as well as confrontation rupture markers. And additionally, it can also tell us a little bit about what resolution strategies might have occurred in that session to hopefully contribute to resolving any ruptures that may have occurred. Now, in addition to that, we also have some global questions, which we rate on a scale of 1 to 5. First, to what degree were ruptures resolved over the course of the session? And secondly, did the therapist cause or exacerbate any ruptures in this particular session? So essentially what this allows us to do is actually watch a session and see, well, was there any rupture going on that an observer would be able to identify? So based on this, my next study had the following aim, which is to determine whether these V episodes that we can see in control charts are actually representative of clinically meaningful rupture process. And I did this by looking at a single case, because I find that one of the easiest ways to do this is to actually go in depth with one particular case. And I'm looking forward to presenting some of this data to you all today. And we had 2 hypotheses based on everything I've talked about already, which is the first is that high alliance sessions, or those high points of the V episode or average alliance, will contain less rupture process as measured by this rupture resolution rating system. And the second hypothesis being that those low alliance sessions or those sudden dips in alliance scores or the low points of the V will contain more rupture process as measured by this rupture resolution rating system. So what we did was really put these control charts to the test and see if what was happening in the sessions really did line up or match up with those control charts. So a little bit about our case that you'll be hearing from a little bit later. Our patient, she was a 35-year-old female at the time of therapy, white and single, having completed a 4-year college degree, and she was employed at the time. Our therapist, who was a psychology extern at the time, actually, was also female, aged 24 and white, and had a master's level training at the time of treatment. And a little bit more about our patient. Based on the structured clinical interview for DSM-4, she met criteria for major depression, which was recurrent at the time, and did not meet criteria for any access to or personality disorder diagnosis. And perhaps just to give you a more depthful sense of our patient, we presented her with the target complaints measure. Now, this measure gives us a chance to ask patients about their presenting problems from their own words, what it is they're hoping to address in treatment. And I found what she wrote quite interesting. So first, she tells us emotional outbursts that are not rational. Most of them happen in romantic relationships, but have also happened in family and friendships. Secondly, I don't believe in myself. I believe I am not capable, and any accomplishment I have is a mistake. And lastly, she writes, I'm afraid if people find out the real me, they won't love me. So these were the things that she was hoping to address in the treatment that she was presenting for. Now, in terms of what that treatment was, she came for a 30-session treatment. This was back over the course of 2013 to early 2014, and this was a 1 session per week format. And we were, the therapist was approaching this patient from a brief relational therapy or BRT perspective. This is an integrative approach that has really been informed by much of this rupture resolution research. And there's a severe emphasis on psychotherapy process in this therapy, which translates to the primary task of therapy actually being to track the alliance, looking for ruptures, and should ruptures emerge, engaging the client in the process of meta-communication, or in other words, talking about the talking process, or talking about the communication that's going on in an in the moment or here and now type fashion. And a little bit about the quality of the alliance. We actually gave the working alliance inventory, again, a way to track alliance scores over time on a scale of 1 to 7. We gave this measure to both the patient and the therapist, and both of them provided us with measures or scores of the alliance for all 30 sessions. And so we have here a summary of those scores, again, both from the patient and therapist perspective. And we actually see for this particular case that the patient and therapist reported the alliance in quite a similar fashion. On average, just about 5.1, perhaps a bit higher of an average on the patient's side than on the therapist side, which is actually quite typical for what we tend to see across data like this. On the patient side, we saw the lowest alliance score of 3.67 and a highest of 5.92. And for patients, for therapists, similarly, a minimum of 4.08 and a highest alliance score of 6.1. So this is just a bird's eye view of what the alliance looked like for this particular case. So I went ahead and constructed one of those control charts we talked about earlier for this particular case. And here's what it looked like. Now, without saying much and just looking right off the bat, I am immediately drawn to what happened here in this mid phase of treatment. So we see session 12 right up here was actually not only preceding a precipitous drop in alliance, but actually is the highest alliance score of the entire therapy. It never quite goes all the way back up to that level after this. And then immediately after session 13, we see quite a precipitous drop, well below that 2 standard deviation level, and even followed by session 14, an even lower drop. So I'm immediately drawn to, gosh, what was going on in sessions 13 and 14 that caused such a significant change in the way the patient was telling us the quality of the alliance was from session 12 just before. So I thought, okay, let's take a look at that and see if the sessions that the control chart is identifying for us are actually worth taking a closer look at and seeing, was rupture actually going on in these sessions like this chart would suggest? So we decided to take a closer look at the following sessions, and I'll walk you through why we chose these particular ones. The first being session 12. Again, this is the start of the V episode we talked about, the highest alliance score immediately preceding a drop. So I started there as almost like a baseline sense of what does a good alliance look like for this dyad. I then looked at sessions 13 and 14, given that these were quite honestly, the lowest alliance scores of the entire treatment. And again, are coming on the heels of this quite high alliance session. And then from there, I chose two more sessions that I was interested in taking a closer look at. The first being session 15, because this is where we first start to see an upward trajectory back from this bottom score on session 14, or the lowest score of session 14. So in session 15, things start to improve once again, and they actually just hit that dotted line of the lower control limit. And I also chose session 20. The reason I chose session 20 is that this is the first time the alliance score exceeds the average alliance score again, or this solid line following the precipitous drop that we saw in the prior sessions. So overall, we took a closer look at 5 sessions in about the mid phase of this treatment. Now, luckily, we also have this wonderful measure of getting a direct sense or a direct report from the patient's perspective of what was happening in those sessions. So I took a closer look at our selected sessions, 12, 13, 14, 15, and 20. And patients in this measure are asked to rate the presence of any rupture, and also the following narrative question, which says, did you experience any tension, problem, or misunderstanding, conflict, or disagreement in your relationship with your therapist during this particular session? So I want to just take you through some of this because I thought it was quite interesting to me what the patient had to say. So in session 12, she tells us no rupture, everything's fine. In session 13, that suddenly changes. She rates session 13 again. That's when we had that precipitous drop in alliance scores. She tells us that there was certainly a rupture present with the score of 4. And she actually gives us a narrative to tell us a little about that. She says, my main problem is how sensitive I am. I don't want to be too sensitive. It is unclear how to fix it because the same conversation keeps happening and we never understand why I act the way I do. So I hear quite a few things in this narrative, but one of them certainly being her feeling that the therapy is not addressing what she's hoping to address, and that she's not feeling any better. And she's starting to feel frustrated about that. So interestingly, I'm surprised, and I'm highlighting here session 14, because if you recall from the chart, session 14 was actually an even lower alliance score than session 13. And yet she rates it on this measure as if there is no rupture. So I just want you to keep that in the back of your mind of how complex rupture process can be, that on one measure, she can sort of indicate one presentation, and on this measure, she's indicating another presentation. So I think this really speaks to the importance of still considering what's actually happening in these sessions, in addition to some of these measures that we can use as tools to help us. So here's some results, and I won't again, bore you with the statistics of this, but I think the main message that I want to get across is that the sessions in which we had highest alliance, which is this purple dotted line or this pink dotted line, were also the sessions in which we had the lowest amount of confrontation ruptures, which is represented by this blue line. Similarly, when we had our lowest alliance scores, session 13 and 14 was when we had the highest amount of those confrontation ruptures. And then we see that as the alliance improves over the course of sessions 15 through 20, that confrontation rupture markers start to decrease. Interestingly, I want to point out that withdrawal rupture markers had sort of an opposite pattern to that confrontation rupture markers, where as alliance was better, or at least the quality of the alliance was reported to be higher by our patient, that withdrawal markers were actually a bit higher as well. But that as confrontation markers became more prevalent, which I take to mean that patient was sort of telling the therapist overtly that things were not going well, withdrawal scores also went down, and vice versa throughout. Now, this is all well and good, but you might be wondering still what was actually happening in this session. So I want to give you a sense of that by actually using some examples pulled from each of these sessions. And I want to start with session 13. Again, that first session where we see this precipitous drop in the quality of the alliance score. So here's what our patient had to say in this session. Patient says, I feel like it's just the same thing over and over. I say I'm too sensitive, I'm too sensitive, I'm too sensitive because I am. And then I'm not supposed to say it. And then it's just this whole discussion. Let's unpack it. Let's talk about why. It just doesn't feel like it gets anywhere. And I keep trying, but I just don't. It's the same thing that I said in one of my first sessions. I just don't see any light at the end of the tunnel for this. All of this seems like over and over and over of the same stuff, and I don't feel like I get anywhere. So this is really in line with, I think, her narrative that she gave us for the end of this session, where she's telling us that she doesn't feel like she's seeing any improvements. This is now 13 sessions in, and she feels as if we're in the same place as she was in session 1, 2, and 3. So let's see what she has to say in the following session, which once again, actually a lower alliance score than the previous, but she doesn't tell us about any rupture, at least on that other narrative measure. So let's see what we found as an example of the dialogue in this session. So patient says, but what kinds of things have we resolved here? Isn't there some stuff, or isn't there supposed to be something we've resolved? Therapist. I mean, you see, I think in ways, this is where we differ. I feel like there has been, exploration taking place. I don't know, I can't think of specific resolutions to problems because I also don't know exactly which sort of issues you want to resolve or what you're thinking of when you say patient. Any. I would go with any right now. Like, I would just like to do a recap, because to me, I don't see any progress and you do. And maybe if the two of us can come together with what I don't and you do, then maybe I could feel a little better, So patient is actually looking for therapists to help her see ways in which, from her perspective, she has improved, because from her experience, she is just feeling like the wheels are spinning in motion and that we haven't gotten anywhere. So let's see what happens in session 15, where things start to go on the upswing. Therapist says, part of me is wondering if it's the emotional experience that's difficult, or it's the judgments that come following the emotion that makes it difficult. Patient says, I don't know. Therapist, what's coming up for you now? Patient, I mean, it just sort of rang true. Like, it does sort of, I guess, feel like, I've just never thought of it that way, but it does feel like I'm just sort of judging myself, I guess. So I think there's a couple things I wanted to point out here that are perhaps reflective of this improvement of alliance scores. The first is that the tone is very different. And actually, it seems that patient is able to once again engage in a back and forth with the therapist on this conversation. And secondly, it seems like in this session that the therapist and patient reach new ground. We are coming across something that previously hasn't been thought of, hasn't been talking about, and comes with a new sense of self-awareness on the part of the patient, where she realizes she's being quite hard on herself in her expectations. And so finally, session 20, we've reached that above average alliance score once again following this rupture or this drop. Patient says, I just felt pretty like, I don't know, I think I said this last week, kind of like this free feeling, I feel clear. I don't know if that makes sense. Therapist, sure, if that's your experience, can you say more about being clear? And patient says, I think clearly. I think more clearly. It's less of like, sometimes when I feel depressed, I feel like a fog, can't really focus. And I've just felt really good, just clear and kind of less worried, kind of more hopeful. So I really love this example because it's a beautiful illustration of how far the patient has come in feeling like she's progressed in therapy. If you remember, when we go back to session 13, really her primary complaint was she felt after all this time, 13 sessions, 13 meetings, I haven't gotten any better. But now we look at session 20, where finally that alliance score has improved once again. And we also see that's coinciding with the patient feeling like she's finally made some progress. So what are some takeaways? Well, via episodes based on between session alliance scores or alliance measures can really be reflective of what's actually happening in the session in terms of rupture process. That when we see that alliance looks high on these graphs, generally we see less rupture going on. And when alliance is looking low or there's been a drop in that score, probably there's some rupture going on that would be worth talking more about in the following session. And this was particularly true with confrontation rupture markers. But one thing I want to point out is that rupture process to some degree really was present, at least in our data, in all sessions. There was not a session where there wasn't a single rupture marker occurring, even those high alliance sessions. And that was particularly true for withdrawal rupture markers. So it's not only something that we could be paying attention to or intervening on when it's particularly apparent, but also just something worth thinking about or having in the back of our minds, even if things are going well. So I think, what does this mean for us in our clinical work? Well, a couple takeaways. Regularly assessing the quality of the therapeutic alliance can help us to identify these ruptures. And I want to take a moment to say that I hope no one walks away from this hour thinking that ruptures are something that should be avoided or even can be avoided. In fact, our thinking is quite the opposite. Ruptures are something that are going to happen inevitably in any kind of dyadic or interpersonal process. But our job is to be aware of them when they happen so that we can intervene and prevent any kind of negative outcome as a result. And we have tools that can help us to do that in a reliable way. One like these control charts, or even just graphing these things, graphing these scores over time can give us a visual clue as to what's going on with the quality of alliance over time, and can really help us to identify, again, clinically meaningful rupture process. And finally, just to wrap up, why is this important? Well, reliably identifying ruptures, right, allow us to intervene in a timely fashion, which provides us an opportunity to get a treatment that's gone off the rails back on track and hopefully see some improvements at the end. So that's my talk. I think I'm right on time, so that worked out. I want to thank you all for having me again. And if anyone would like to continue this conversation, I really welcome you to email me, and I've provided my email there. So thank you very much for your time.
All right, thank you so much, Dr. Lipner, and you are exactly on time, so you are right about that. I appreciate
All right.
that. And so what we'll do now is take a look at the Q&A section, and if anyone has questions, and please do enter them there. We're going to ask them to Dr. Lipner one at a time. Thank you for your excellent presentation. And your first question is from an anonymous attendee, and it is, thank you for your talk. Was the rater of the sessions in your case series blind to the YAI scores?
Great question. Thank you for your question. Yes, absolutely. They were blind to whether the session was coming from a high alliance session or a low alliance session. So absolutely, our coders did not know what the WAI scores were.
Okay, and this next one is from Lisa Cohen. Do you think the rupture in session 13 had anything to do with the highest score of the alliance in session 12? Is she rebounding from a high by dipping lower?
It's really possible. And this is always, a thing that we're dealing with when we have extreme scores, going from that highest alliance to suddenly this precipitous drop. It's possible that something was going on where the patient suddenly became disillusioned with what was happening in the treatment and perhaps came to a new awareness. Wait, I thought things were going well, but I'm actually realizing I still don't feel any better. And in comparison to how I thought things were going, it's just not where I thought I would be. So it's really possible that there was a sort of comparative process going on. And I wish I could talk to the patient now and sort of ask her. But yes, I think that certainly these things don't happen in a vacuum.
Thank you for that. We actually have a couple of questions in the chat, which I'm going to read to you as well.
Okay.
We've got from Matthew Majeski. I'm reading your name wrong. I apologize. Was she taking medication? Serotonergic and antidepressants tend to make patients more phlegmatic.
Thank you for your question. As far as we know, she was not seeking any psychiatric care at the time of this treatment. That is an interesting question, though, thinking about our patients more broadly, just beyond this case, how these substances might impact interpersonal process in this way, but not the case with our patient here that I presented.
Great. And this is from the chat too by Carl Goodrich, who missed the first couple of minutes of your presentation. Who was filling out the rating forms for YAI? It sounded like the therapist and patient both completed them, but I wonder if they were rated by an observer as well.
Yes. Thanks, Carl, for that question. So both patient and therapist told us their sense of the alliance score for that particular session. The chart that I presented was based on the patient scores. The therapist's chart did look quite similar, but I didn't show it here today. I did have the codes, the coding of the rupture markers were done by observers. So we actually had 3 perspectives on each session, one from the patient, one from the therapist, and also a third-party observer who had no idea how the other parties rated the alliance.
Great. Well, there's lots of questions now. Again, if anyone has anything, please enter it into the Q&A. Lauren, how is it presenting in this webinar format? It's very strange, non-personal format for you.
It's funny. I can't see how anyone is reacting. So hopefully I was clear, but certainly if anyone would like to reach out to me to talk more, I really do welcome communication because I have no sense if you were with me or not. And I felt like I was talking into the ether, but I'm glad to know that some of this came across.
Well, it's an interesting point and related to your topic, right, about rupture and prayer. I wonder if you know, or you yourself have done any research on the difference between the therapeutic alliance in virtual sessions and in-person sessions.
So this is research that of course, unsurprisingly, in the past couple of years has started taking off. We ourselves in the brief psychotherapy research program at Mount Sinai Beth Israel, when the COVID pandemic hit, had to switch everything suddenly from all in-person operations to everything over Zoom. So we are now collecting data on this from a purely remote perspective. And I think our hope, our future goals is to sort of start to compare what changed when we had to switch to over Zoom. But I do know some preliminary data has sort of started suggesting that the alliance is just as important, whether we're in person or not. But hopefully we get some more details on that in the coming years.
Yes, but all things we all want to know since we're all doing virtual work. All right. So you do have a new question, more than one here. We've got something from Allison Madnick, and she says, this is not a question, but I used to be a member of Dr. Banks' lab and used to code therapy sessions with the 3RS, which was quite challenging. Thank you so much for this presentation.
Oh, I'm glad to hear.
Okay. And this is from the chat. Looks like it's also from Carl Goodrich. Thank you. Are there any general readings that you would recommend about the therapeutic alliance or rupture and repairs?
Oh, great question. So actually, I did have it right on my desk. There's a new book that just came out by the primary investigators of this research program, Chris Moran and Catherine Eubanks, called Therapist Under Pressure. This just came out, I think, in 2022, which really summarizes all of this literature we know in terms of the theoretical background of the therapeutic alliance and rupture, and also once we know they happen, which is really what I've talked about today, once we know what they've gone on, what do we do? How do we address them? Which I didn't get to talk about today, but that book certainly has some good resources for that. You may also check out our website, therapeuticalliance.org. We have many resources on there that you might be interested in checking out, including some video demonstrations of sessions and rupture repair processes. So that might be useful to check out as well.
Great. Lauren, if you could, are you able to put that website into the chat or the title of the book?
Oh, absolutely. Yeah, I'll pull it up for you. Okay. Oh, and I see Dr. Lisa Samstag is reminding me there is a new book. I'm not sure if it's come out yet, but if not, it's coming out this year imminently, called Rupture and Repair in Psychotherapy, which is going to be a great resource because it covers these topics from multi-theoretical perspectives. And Lisa Samstag is telling me it's out. So we have these ideas covered from a cognitive behavioral, psychodynamic, and everything you can think of perspective. So you can find ways it applies to your personal practice and approach.
Great, thank you for that. And there was something else you mentioned, was it the title of the book?
Oh, yes.
You had recommended? Therapist Under Pressure.
Under Pressure.
Just give it another minute to see if there are other questions. Well, I don't see any questions. You have another thank you for an amazing presentation and great topic comment.
Great.
So yes, thank you, Dr. Lipner. We really appreciate your presentation, and I guess we'll wrap up your portion now. And I'll just say to everyone, thank you for attending Psychology Grand Rounds. And as a reminder, we do this every month, or I should say most months, except sometimes in the summer we skip a month. So we are up for the next Grand Rounds, the first Friday of April 7th. So hope to see everyone there. And thanks again, Dr. Lipner. Take care, everyone. Have a good weekend.
Thank you.